Turn on my video here. All right, fantastic. Make sure I can keep all these screens going. We have a few different things going on all these computer screens here today. But good afternoon, everyone. I'm really excited to be with y'all. Again, my name is Morgan Bowne, and I'm the Director of Member Engagement and Workforce Development here at the South Carolina Hospital Association. I'm really excited to be with y'all and hope you find this discussion both beneficial and engaging. Worker safety and more specifically workplace violence has been a top priority of the workforce team at SCHA for many years now. There has certainly been an increased focus on the problem recently, and we're hoping that this can fuel many of the efforts needed to make change and improvements. And before we really get into this, I'd also just like to say Happy Veterans Day to any veterans who may be with us both virtually and in person today. Here we go. Okay, so for a little bit of background information, there we are. On SCHA, or for those who are not as familiar with SCHA, we are a private, not-for-profit organization, and we were founded in 1921, so we've been around for a while. We are currently celebrating our 100th anniversary right now, so it's been an exciting time to reflect on the great work of our member hospitals and all the partners that we've worked with throughout the past 100 years. We do represent all hospitals in South Carolina, meaning that all of our hospitals, if you drive past a hospital, they're a member with us. So we're very blessed in that respect and have worked really hard to get to this point, and that does include rehab facilities. So we currently represent, as you can see on the slide, about 95 hospitals and health systems as independent or, systemized facilities, and that accounts for also about 900 professional membership group members that we have here at the association. So I've already mentioned that SCHA has been working on workplace violence in healthcare for many years, but oops, sorry, had another old slide above there. But you may be asking why, like, why are we focusing on this again? Why have we focused on this before? Why are regulators watching this industry specifically in healthcare and workplace violence right now so much? So the why is actually pretty simple and straightforward, and many of you who are familiar with this may already know. Workplace violence is a major safety issue in hospitals and health systems across South Carolina and the United States alike. Studies have shown historically that healthcare workers are much more significantly more likely to be the victims of violence and abuse than workers in other industries. So the U.S. Bureau of Labor Statistics reported between 2011 and 2018, the incidence of serious workplace violence, meaning that those events that required days off of work, were 5 times more common in healthcare than in a private industry on average. So that is pretty significant. In a healthcare environment where high reliability is paramount and very important, both physical and verbal abuse are significant contributors to workplace violence and stress, psychological trauma, and many other things that can negatively impact our employees' health and quality of life. Some potential sources of violence in healthcare facilities vary widely and can include patients, visitors, intruders, and even coworkers. I mean, we've even heard about incidents of, chaplains being assaulted or people being bothered by delivery personnel. So it really does cross the entire spectrum of anyone who's entering the facility. There's also a lot of research that indicates that workplace violence in healthcare is vastly underreported because many employees believe that it's part of the job, which is simply not the case. So SCHA is very committed, as we have always been, to making hospitals a safer place to work, visit, and receive care, which is exactly why we focus on this issue. So to share a few definitions here with y'all, I have 2 on the screen for you to review and compare. There are similar ones, just a little bit longer, but in the past, we've only had one definition to work from, and that's been from OSHA. So OSHA defines workplace violence as any act or threat of physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs at the work site. The second definition you see is from the Joint Commission, who has really just recently joined the conversation. Not that they haven't been a part of workplace violence, but they have more so started to issue formal recommendations around it. With new and revised requirements addressing workplace violence, prevention programs becoming effective in January, actually January 1st, 2022. So that's coming up upon us very soon. The Joint Commission now defines workplace violence as an act or threat occurring at the workplace that can include any of the following. So you see verbal, nonverbal, written, physical aggression, so on and so forth. That's a lengthy one, but it is pretty comprehensive, and it's one that we like to use now since it is so comprehensive and well-rounded in everything that it covers. So as you can see, both display how workplace violence ranges from physical threats to verbal abuse, even homicide. So this is a huge step in acknowledging the different and varying types of violence impacting healthcare workers. So OSHA, as you can see again on the screen, recognizes 4 types of workplace violence, and that this is the organization we'll focus on first since they do have the most guidance out there and the most information over the past few years. So you can see that for the first type is criminal intent. For the second type of recognized violence, examples, which is the most common in healthcare, you'll see a few different examples, such as violence directed at employees, by customers, clients, patients, students, inmates, which we do see in hospitals, or any other to whom the employer may provide a service. So a lot of this may also, and specifically in hospital, include distraught family members who may be abusive, active shooters, things like that, or gang violence that makes its way into the emergency department, sometimes related to a shooting. OSHA does not currently have regulations specifically related to the prevention of workplace violence in healthcare settings, but they do have a specific requirement saying that each employer shall furnish to each of his employees employment in a place of employment which are free from recognized hazards that are causing or likely to cause death or serious physical harm. This includes, and this is the important part, this includes the prevention and control of the hazard of workplace violence. So again, it's not a specific regulation, but they do have pretty solid guidance there for our hospitals and other healthcare entities to reference. And then the third and fourth type that you can see are coworker workplace violence, which again, sadly, is pretty common in healthcare, and personal. So to give you a little bit of data here to check out, which I always find this to be the most fascinating part. In 2018, you can see that data from the NIOSH, which is the National Institute for Occupational Safety and Health, is highlighting that 9,200 healthcare-related non-fatal workplace violence-related injuries were reported throughout the year. So that's a pretty significant number. And this number, that 9,200, accounted for more than 73% of non-fatal workplace violence-related injuries across all industries. And as you can see, again, most of these incidents were perpetrated by patients or their family members. So I'm sure for many healthcare professionals in the room, this is hitting home and not a surprise for many of you. And I'm going to show you a little bit of data in these next few slides because I feel like data does the most effective job of telling a story rather than anecdotal information. So by looking at this chart titled Intentional Worker Injuries on the Rise, and this is from the U.S. Bureau of Labor Statistics again, you can clearly see that the rate of intentional injuries for healthcare and social assistance workers is significantly higher than the other industries shown. So that is that lovely big red line going significantly more towards the top of the screen than all of the other industries represented. And we had very similar findings from the U.S. Department of Health and Human Services. They had data that indicated that the rate of non-fatal injuries among healthcare workers in public hospitals in 2018 was 10.4 per 10,000 workers. The U.S. Bureau of Labor Statistics also showed us in 2014 that of 15,980 private industry workers who experienced trauma from non-fatal workplace violence, 67% were female and 69% worked in healthcare or social assistance. Something I think that's also really important to just talk about here as we're going through all this data is that it may seem a bit dated, and that's because it is. We've had a lot of time, we've spent a lot of time trying to collect data, not only in South Carolina, but nationally as well. And it's been very difficult to track down workplace violence incidents for a variety of reasons due to how organizations define the problem, That's again why I shared those two definitions at the beginning. I think it's really critical that we all pick a definition and kind of go with it so everybody's using the same baseline as how they're defining these incidences when they do occur. We also see a lot of instances where healthcare workers put their patients first and the patient's family members first, and they just aren't as willing to report. It's very common for healthcare workers to not report these incidences. And again, they just sadly think it's part of the job. It's something that they were exposed to. If we're using nurses as an example, potentially in nursing school, it's just always been a part of their daily workday. So they're just not as likely to report it. So if you look at these numbers and how much higher they are, and then take into account the fact that the majority of cases are not even reported, that tells an even bigger and scarier story of how big of a problem this really is. So this is of no surprise, but as you can see from the past few slides, the most readily available data on the most workplace violence research ranges from the early 2000s again to 2018. And sadly, we haven't seen much new data, largely in part to COVID. Tracking workplace violence incidences probably hasn't been the top priority for our health systems and hospitals, as you've been taking care of very sick patients and trying to navigate staffing shortages and supply shortages, supply chain issues, all sorts of things. There's just been so many rapidly changing environmental situations and anything you can imagine, I'm sure. So all the stressors have not led us to be surprised that there is even less data right now than there was before. So this specific chart, featuring data from 2013, again, a little bit dated, shows that 80% of serious violent incidences reported in the healthcare setting were caused by interactions with patients, which isn't as surprising. The others shown on the slide, indicate other clients or customers, students, coworkers, and other unspecified person, or an assailant, suspect, or inmate. So again, I'm sure nobody is super surprised that it's mostly patients who are the perpetrators, but again, it goes back to why you also see the underreporting that we referenced in the last slide. So this all brings us to a very strong conclusion, right, that healthcare is more dangerous than other industries to work in. The data makes that very clear. And this is due to a few things. Healthcare workers have to work with people with violent histories. They don't get to choose who walks through that emergency room door or who needs treatment. It's just their job to take care of them as best as they can. So they tend to see those people with violent histories, people with substance abuse issues. They're also, moving, transporting, having a lot of hands-on contact with these patients in the facility. And there's also a lot of unrestricted movement and patient access in a hospital. That has changed more recently during COVID due to lockdown protocols and limited visitor hours and a lot of visitor restrictions. But there's still so much more opportunity for people to have hands-on contact and be alone with patients in a room where it's just one caregiver and the patient. So that's a lot of what brings us to why this is more dangerous. And then there are a few other reasons on the screen that you see. Some hospitals are in high crime areas, poor environmental design and poor lighting potentially based on the facility and how old it might be. And then you're also going to have just the general aggravated nature of patients and family members when they've had to wait for a long time, when the ER is overcrowded or other waiting rooms are crowded. It just causes a lot of stress and tension where people are already really stressed and tense when they're receiving care in a hospital because they're usually pretty sick for the most part. So it's just kind of the perfect storm in that respect. And again, I won't stay on this one too long because we've touched on this in a variety of ways, but the data is lacking, again, mostly because healthcare workers don't report. They either feel there's a lack of support within their organization or that when they do report that nothing will really be done about it. They believe it's just part of their job, something that they just signed up for, or there may even be a knowledge gap on the issue. A lot of caregivers that we've talked to didn't even really understand that verbal abuse was abuse, and that was considered workplace violence. They just have become so accustomed to it, sadly, that they thought it was something normal and something they should come to expect. So what are the associated costs? And there's a few in a few different realms. Although some of it is financial in terms of time away spent from work, covering shifts, many of the costs are not specifically related to dollar amounts, although we will touch on the dollar amounts next. So some of these non-specifically financial related measures include medical treatment for physical injuries that may have been sustained at the work site and time away from work, short and long-term psychological impacts on the employees. Sometimes that will require therapy. We've also got employee turnover. We see a lot of that right now related to COVID, but you also saw that previously in healthcare where people just got tired faster. They got worn down. They just couldn't keep going with these, violent patients, disruptive patients, aggressive patients. To property, litigation, insurance claims, and caregiver fatigue, issues with presenteeism, and again, the injuries and the stress. It also may even be linked to issues with patient care and medication errors and infections and things like that. So it goes far beyond just saying that the patient was verbally abused or physically abused and had to go back to the next patient, or maybe they couldn't go back to the next patient. It encompasses a lot more than that. So for those who may be numbers people in the audience today, if you're looking for data that is more financially focused, then you would want to look at a report specifically prepared for the American Hospital Association, our national counterpart in 2017. It's a really great resource. This specific report estimated that workplace violence cost the U.S. hospitals and health systems approximately $2.7 billion in 2016. So that includes $280 million, as you can see, in money related to preparedness and prevention, $852 million in unreimbursed medical care for victims, $1.1 billion in security and training costs, which is a good thing. I wouldn't necessarily deem that one a consequence. There should be appropriate security measures and training put into place and implemented for our team members. And then finally, $429 million in medical care, staffing, indemnity, and other costs related to these events. So that's a lot of money. Not just for the hospitals, but for insurers, for all the groups involved. So now that I've told you more than enough than you probably ever wanted to know today about why this is the problem, we can kind of focus to how SDHA has focused on it, what we've done in the past, and what we plan to do in the future to really make a change, or hopefully make a dent, at least with South Carolina hospitals, in helping them find ways to combat workplace violence and make their hospitals a safer place to be. So since 2013, again, for those who are familiar with us, you may know a little bit about this, but for those who are not, SDHA has worked towards improving quality of care through our Certified Zero Harm Awards program, which is directly tied to high reliability, which is essentially saying, we want to hold ourselves highly accountable and make ourselves the best centers, hospitals, health providers in providing care for our patients. So that work has in the past primarily focused on the safety of the patient, but we want that to change. So in 2019, or I guess we wanted that to change. So in 2019, pre-COVID, let's all go back to those fun pre-COVID times before people were doing hybrid presentations and the hospitals and multiple other places had visitor restrictions. SDHA took this zero harm approach a step further and decided to create a toolkit for our member facilities and hospitals around workplace violence to focus on the safety of employees and, in addition, our staff, and add this into our patient safety measures. So again, taking it from just a patient focus to a patient and staff employee safety focus. So this decision came from a few different groups that we relied on heavily at the time for input. It came from SCHA's Workforce Advisory Council, which involves chief nursing officers, chief human resource officers, chief operating officers, and other educational partners throughout the state from other industry-related groups. SDHA's regional leadership councils, which represent 4 regions of the state. We meet with them 3 times a year to collect feedback. It was also supported by SDHA's Workplace Safety Task Force, which we created as part of this work, and I'll get to that next. And all of this work was supported by the SDHA Board of Trustees, of course. We always need their support, and they are fantastic about jumping on board and helping us see initiatives through. So as I said, we will now talk a little bit about the Workplace Safety Task Force that we formed. Most importantly, in this group, we wanted to have hospital employees involved in making decisions related to the directions of our efforts. We are not big fans of just sitting a few SCHA employees in a room and saying, we think this is a great idea. Although we do come up with some pretty good ideas, we want to hear from the people who, like what we want to call our boots on the ground. Those who are related to making decisions are in this, down in the trenches daily, experiencing this. So we started by forming our Workplace Safety Task Force. This group included a variety of professionals from 38 different hospitals across the state. Membership included some chief executive officers, chief nursing officers, other physician leadership, emergency management professionals, safety officers, legal counsel, and many others. So it was a pretty thoroughly represented group, which was exactly what we were looking for. And this group of individuals essentially identified a few starting points for our efforts, to include creating communications tools, a culture and process toolkit, which we'll talk about a little bit later, and also went in the direction of hosting a webinar series to help launch all these efforts, essentially featuring hospitals that had already excelled in certain areas of this work to make sure that we capture their best practices and could bring them back to the table to learn from. So through the creation of this campaign, we looked really closely at other industries with good track records of high reliability in clinical practices, as well as reducing harm. Something that our CEO has mentioned a few times to me since I worked at SCHA, and I've also heard spoken at other meetings, is that the airline industry has a huge focus on a culture of safety. They have done a fantastic job of taking a problem, identifying it, and eliminating the majority of risk associated with that. So the airline industry is always one that tends to take people off guard, but it's something that we like to look at when we're considering a lot of this risk reduction, harm reduction work. So the goals of this group, again, that we worked with in 2019, we had 4 primary goals. We wanted to reduce the risks, incidences, and costs of staff-related injuries related to workplace violence. Secondly, we wanted to implement new evidence-based best practices to enhance a culture of safety. So that goes back to the webinar series, as well as, again, just bringing together that group of people gave us an opportunity to hear what everybody was currently doing, what was working well, what wasn't. We wanted to empower healthcare employees to create safe working environments and to be a part of the decision-making process. And we wanted to proactively address risk and safety issues related to employee safety. So we started all that with our Hospital Safe Zones campaign. As part of the work of the Workplace Safety Task Force that SCHA launched, we also, at the same time, or at the conclusion of that work, I guess, of the task force, we launched this Hospital Safe Zones campaign with the goal of really educating healthcare providers and the public jointly on the impact of workplace violence in healthcare. And this was the first piece of launching all of this work. So we really wanted hospitals and other health facilities to be held to a higher standard visibly for the public, so that it wasn't just all this work that we were putting on the hospital. We wanted them to see that we wanted the community to take part in this too, because the hospital can do everything within their reach. But again, as we saw in that chart earlier, 80% of these incidences are caused by patients, and where are the patients coming from? They're coming from the community. So we needed to make sure to include them in this process as well. In addition to the communications campaign, we created a toolkit, a very lengthy one at that. If you want to check it out, it's at www.hospitalsafezones.com. That is part of what I'll reference later that we'll be revamping, hopefully this year and into 2022. But we did compile a lot of resources into one place. So again, this was the second component of those task force efforts, and it focused on the launch of a toolkit that the hospitals could essentially use to guide them through the process of creating and implementing or improving their workplace violence prevention programming. It's very thorough, and it includes all the items you see on the slide. From a handbook, it had sample policy forms, lots of checklists, white papers, different research. We were sure to source all of our resources and list them there so the hospitals could go back and reference them if they had any questions. And we also made our team readily available to answer any questions that they had to make sure that this was a smooth implementation process. And then the third piece that isn't listed here, but we did do, and it was a huge success amongst our hospitals, was a webinar series. And that included 4 different webinars hosted by our hospital members that focused on protecting employees by building an environment that doesn't tolerate violence, changing management strategies and achieving buy-in and finding success, creating and fostering a culture of zero tolerance and reporting strategies with workplace violence, and then legal insight and data collection, what you need to know. So all of this touch on the variety of things we've talked about already today. So these are just a few examples I'm going to show you really quickly of the campaign I mentioned earlier. So again, hospitalsafezones.com is our landing page. It has all of the resources that we're hoping to revamp this year, as well as the resources that we've used in the past, and we'll be adding new things as well, hopefully. And as the campaign was promoted, our communications team here at SCHA really encouraged hospitals to use photos of their own team members on the flyers and posters and other content that they shared within their facility. And this makes it more personal. It helps employees connect more. You know, if they see their teammate in the hallway or in the break room where this do no harm poster is posted, or more specifically, I guess the break room would have it's not part of the job, and you'd have the do no harm out in the hallway. But again, it's creating a sense of connection to the work. It achieves some buy-in, and it also provides a sense of recognition by leadership to want to involve their own team members as well. And speaking of leadership, we similarly encouraged members of leadership team not only to support this effort so that it can be implemented, but to put pictures on them of themselves on the pieces of communication to their staff members, with messaging focused on supporting the reporting of incidences by staff. Because again, if you aren't reporting the problems, leadership either doesn't know they're going on, or we can't do anything specific about it if we don't have any data backing that up, saying, you know, this department or this specific area is struggling most in the hospital right now with workplace violence. So that leads us up to, where do things stand now? The Toolkit launch was successful in 2019, and we saw many hospitals participate in implementing components of the Toolkit, which was fantastic. Included all the things I told you about. However, we're now in a much different place than we were in 2019. I think we can all say. I want to laugh saying that, but it's really not that funny. We are in a very much different phase. And then I say, you know, enter COVID-19, which changed all of our lives, both professionally and personally. Specifically related to healthcare, it's changed the landscape for hospital security in more than one way. With, you know, more visitor restrictions, we were anecdotally made aware of significant decreases in a lot of our hospitals and workplace violence events, not just from patients, but from visitors too. So we similarly had clinicians note that their patients were able to get better rest. So they were having better patient outcomes with some of these patients who didn't have visitors coming in and out of the door constantly. At the same time, I'll tag that with, we also heard that staff took on a lot of additional stressors in terms of having to communicate on behalf of patients with their loved ones while they were an inpatient and no one could come see them. So if we have listened and learned alongside a lot of our hospitals, which is a big part of our job here at SCHA, is just be here to listen, learn, help troubleshoot, and navigate problems. In COVID-19 and before that, we've recognized that it's important to strike a balance between, or strike a balance and find a happy medium where both the patient has support from their loved ones and the staff aren't constantly bombarded with patient visitors, while also figuring out a way to keep maybe less extra people out of the room so that the patient gets quality care, but also our caregivers feel more comfortable and hopefully see a decline in the rate of workplace violence, or a continued decline. So incorporating all of these facets that I've mentioned into our efforts moving forward is a top priority. And then another thing to keep in mind that I referenced more so towards the beginning in terms of workplace violence is the issuance of new and revised workplace violence prevention requirements from the Joint Commission. Those will be effective January 1st, 2022. And these new prevention requirements are going to focus on, or will be put in place for all Joint Commission accredited facilities and hospitals and critical access hospitals alike. So If you're a Joint Commission hospital, then this is for you. These requirements are going to provide a framework that will essentially guide facilities in developing strong workplace violence prevention systems and address the concepts that I'm going to show you on the next slide. But again, keep in mind, this is just Joint Commission facilities that I'm talking about for the next slide. So the new revised requirements are going to focus on all the things you see here. Defining workplace violence will have a formal definition, which, as I said, I'm a huge fan of because we all need a definition to go by. Leadership oversight, a worksite analysis, policies and procedures for prevention planning or training, reporting systems and data collection, as well as a process to analyze that data, which is very important. Again, right, we lack a lot of data, so we need to have a formalized way to collect it, analyze it, look at it. Post-incident strategies, what are you going to do once they do report it? That's a huge reason why staff don't seem to want to report these incidences, is because nothing's done. So it's critical to have a post-incident strategy of how it'll be handled immediately, as well as in the coming days, weeks, and months after the incident occurs. And then training and education, which is critically important to decrease workplace violence. Again, we can never have too much education on this specific issue. So in revamping the campaign that I mentioned, our Hospital Safe Zones campaign, and with the the impacts of COVID-19 and the revised requirements, or the new and revised requirements from the Joint Commission in mind, the workforce and communication teams at SCHA have been brainstorming and decided to revisit our work around workplace violence. More specifically, do a deep dive into everything we created in 2019 and kind of bring it up, edit what we need to, as well as add some new resources. So as I mentioned, there's a good bit of content that we really need to update as much as possible, but we're planning to start by partnering with the Health Science Services Advisory Group, also known as HSAG, to develop an assessment tool. Ideally, hospitals will be able to use this tool as a quick way to assess where they currently stand with workplace violence prevention programming and efforts, and where they can improve. So we want this to be a quick takeaway where they don't have to use necessarily that whole 20 or 30 page toolkit, and can just take a look at this toolkit and say, or this checklist, and say, okay, where do I stand in terms of education when they're onboarded? Where do we stand in terms of post-incident response? Where do we stand in terms of, how patients are allowed to enter the facility, and what visitor restriction hours look like, and things like that. So we, again, partnering with HSAG on that, and we're very excited to do that, bring another group in and kind of get their opinions. So to kind of wrap us up here, I like this quote that I've seen a few times from the American Nurses Association that it was issued in 2015. It was a position statement on incivility, bullying, and workplace violence, and they stated the following. They said all RNs and employers in all settings, including practice, academia, and research, must collaborate to create a culture of respect that's free of incivility, bullying, and workplace violence. Evidence-based best practices must be implemented to prevent and mitigate incivility, bullying, and workplace violence, to promote health, safety, and wellness of nurses, and to ensure optimal outcomes across the healthcare continuum. So for us, this captures a lot of what we wanted to do. And again, this is from the American Nurses Association and references nurses, but we focus on all the professions involved in a hospital, from environmental services and patient check-in to administration, obviously to all the clinical caregivers who probably experience the heaviest load of workplace violence. And we're hoping essentially to spark a collaborative effort among our hospitals and other health professionals to promote health, safety, and wellness of all employees in a healthcare setting while providing optimum patient care. And for this to be successful, we must engage employees in all areas of practice. So again, not just nurses, but this is a really good way. I thought this did a great job of just capturing what needs to be done by all entities and groups in a healthcare system. So again, that's really the gist of where we've been, how this issue came to our attention, what we've done to date, and what we plan to do in the future. So I want to throw it out there, see if anybody has any questions. If not, I can toss out a few questions if y'all are interested, and if not, we can wrap this up. But I guess I'll open it up to the floor now and see if anybody has anything specific to ask.
We have a question in the room.
Okay.
Thank you. I know that before COVID, SCHA had a plan for April, I think, of 2020 to have a workplace violence awareness month. Is there any plans to do that again initially?
Yes, that is definitely on our radar as something to continue. A lot of our legislative efforts, as you referenced with COVID-19 and our other efforts, got tied up. All of our political momentum got tied up in COVID-19, but that is certainly something that we would love to continue and hopefully advocate to happen again.
Okay, will there be a PR campaign with local media outlets by any chance?
Yes, our communications team would definitely include them.
Thank you.
Anybody else?
If one of the hospitals was interested in becoming part of the workplace task force or wanted to be involved in these more substantive ways, how would they let SCHA know that they were interested in doing that?
You could contact me. I will work hands-on very much so with the task force, as well as Laura Hewitt. She's our VP of Workforce and Member Services or Member Engagement, if you're familiar with her. But you could just shoot me an email. My email is M as in Morgan, BOWNE @SCHA.org. And my email is also on the website. So if you didn't catch that, I know I have a little bit of a unique last name. All of our email addresses and contact information is on our website, which is just SCHA.org.
Great, thank you.
Mm-hmm.
I have one more question. I know back in 2019, when we were working on the Hospital Safe Zone Initiative, there was discussion on using the data that the hospitals can provide around their workplace violence incidents to try to get the government to enforce those harsher penalties for people who assault healthcare workers and first responders. Is that something that we're going to start back doing? I know COVID came in and kind of postponed a lot of things, but I think that was a great initiative to be working towards.
Yes, so that's a great question. We would love to restart the data collection piece. We started out strong and got participation by a good number of facilities, but that did drop pretty significantly during COVID. I think we had an important lesson learned from that as well. The task force had a great intent in the tool that we sent out to collect that data, but really it was asking for a lot of information for one person to put in. And now you mix in all the staffing shortages and other issues going on in the hospital. So we will be revisiting that tool and trying to whittle it down a little bit so that it's more, digestible, easier to use. Because you're right, that data is a very important piece in formulating a lot of our strategies and how we'll move forward, both legislatively, as well as just in every other sense of how we're moving this work forward.
Anybody else? Thank you, Morgan.